Hello, and thank you for joining us for our webinar today, Identifying Malnutrition in Pediatric Oncology Patients Through Nutritious-Focused Physical Exam. This has been brought to you today by the Oncology Nutrition Dietetic Practice Group. Our speaker today is Holly Van Poots. She graduated with a degree in Human Nutrition, Foods, and Exercise from Virginia Tech, and then completed her dietetic internship at the Medical College of Virginia Hospitals. She currently resides in Virginia, where she owns B Balanced Nutrition, a private practice specializing in integrative nutrition care for all ages. She has over 15 years of experience working with acutely ill children in several large health systems and has been board-certified specialist in pediatric nutrition since 2006. She has served as a subject matter expert for the Commission on Dietetic Registration Pediatric Specialty Exam and has been a member of the advisory committee for the University of North Carolina at Greensboro's Dietetic Internship Program. She became a fellow of the Academy of Nutrition and Dietetics in 2015 and is past chair of the Pediatric Nutrition Practice Group. She's also been an editor for the PNPG Building Block for Life. She is currently copy editor for the Dietitians and Integrative and Functional Medicine newsletter, the Integrative RDN. Holly is a dynamic speaker and is dedicated as a leader with a passion for healthy living for her family. Outside of nutrition, she spends her time raising 2 boys and teaching Pilates and bar group fitness classes. So it sounds like you are very busy, Holly. Thank you very much for taking time to present to our group today.
Thank you. I'm so glad to be here today to speak with you guys about identifying malnutrition through nutrition-focused physical exam in the pediatric oncology population. This is a subject that's very near and dear to me. Not only do I have some background in pediatric nutrition-focused physical exam, but before I moved to Harrisonburg about 2 years ago, my most recent clinical position was as the pediatric oncology dietitian at Brenner Children's Hospital in Winston-Salem, North Carolina, which is part of the Wake Forest University Baptist Medical Center. So I loved my job there, and that's really what kind of got me involved in integrative nutrition and really in identifying malnutrition for this subset of patients that is really vulnerable and is also really ready and set to be able to be influenced by nutrition care plans that we implement as the registered dietitians. So our learning objectives for today are 1, to outline criteria for diagnosing pediatric malnutrition, 2, to identify malnutrition risk factors over the course of childhood cancer treatment, 3, to describe the components of a head-to-toe physical exam, and then 4, to identify focus areas for NFPE in the pediatric oncology patient population. So we're going to start with a little review of pediatric malnutrition. Hopefully most of you are familiar with this paper that came out in 2013 called Defining Pediatric Malnutrition, a Paradigm Shift Toward Etiology-Related Definitions. And there were a few things that are very unique about this paper. The first thing that it did was gave us a standardized definition for pediatric malnutrition that had been lacking in the literature prior to this paper's publication. That definition is an imbalance between nutrient requirements and intakes, which result in cumulative deficits in energy, protein, or micronutrients that may negatively affect growth, development, or other relevant outcomes. Another unique part of this paper was that it outlined 5 key domains related to pediatric malnutrition. Those were anthropometry, etiology and chronicity of malnutrition. So this was the first introduction of the concept of illness-related malnutrition or non-illness-related malnutrition, as well as the acute or chronic malnutrition timeframes, with 3 months being the delineator there with that. So also the last 3 key domains were mechanism, imbalance, and then outcomes. So one thing that was important about this paper is a lot of the previous literature had to do with malnutrition in developing countries and not necessarily in hospitalized children. So this paper really was a call to action for the healthcare profession and the medical community to look at illness-related malnutrition in developing countries in hospitalized children. So I think that's probably the population that applies to most people that are listening today. So another key component of this paper was, in the definition of illness-related malnutrition, it listed 4 mechanisms for that development. Those could be decreased intake or starvation, increased requirements or hypermetabolism, increased losses, or altered utilization of nutrients. So following that paper in 2013, in 2014, the consensus statement of the Academy of Nutrition and Dietetics and ASPEN was released with indicators recommended for the identification and documentation of pediatric malnutrition, specifically related to undernutrition. So hopefully most of you are familiar with these as well. We're just going to review them quickly. Those consensus statement indicators are broken down into indicators for less than 2 years old and indicators for greater than 2 years old. They have to do with either weight for length or body mass index, length or height, mid-upper arm circumference. They also take into account growth velocity or weight loss, a decline in weight for length Z-score, or a decline in BMI for age Z-score. Then they also compare dietary intake with estimated requirements. So the rows that are listed for you in green or bluish color require one data point. That's going to be the Z-score value for those measurements. So the data point is the number or the value, whereas the indicator is the characteristic that we're looking at. Then the bottom 3 rows, which appear in purple, require 2 data points or 2 values in order to make a diagnosis of malnutrition. A couple of things to remember here with these consensus statement indicators are that only one indicator is required to diagnose malnutrition in the pediatric population. This is different from the adult malnutrition consensus, which requires 2 indicators to diagnose malnutrition. Even though we only need 1 for a diagnosis, you should still be evaluating all age-appropriate indicators, and many times you'll use the most severe indicator for a diagnosis if you get indicators that are consistent with varying levels or degrees of malnutrition. So let's dive in a little bit more closely to the primary indicators, which require only 1 data point. So weight for length is the measurement that's going to be used for the population of 1 month up to 2 years. That's because this consensus statement applies to 1 month up to 18 years of age. So from 1 month to 2 years, we will look at the weight for length Z-score, with mild being defined as a Z-score of -1 to -1.9. Moderate is a Z-score that falls in the range of -2 to -2.9, and severe malnutrition being a Z-score of -3 or below. For the ages of 2 to 18 years, we look at body mass index for age. The same Z-score parameters apply here in this situation for mild, moderate, and severe. Then we look at mid-upper arm circumference. According to the consensus statement, it can be used as a diagnostic indicator for malnutrition in the 6-month to the 5-year-old population. Same Z-score parameters. And then finally, we have length or height for age, which applies for 1 month up to 18 years. We don't use that to make a diagnosis of malnutrition unless the Z-score falls at -3 or below. So then, moving on to those indicators that require 2 data points. The first one is going to be growth velocity for our less than 2 years of age population. And we are going to look at mild malnutrition as being considered less than 75% of the norm for expected weight gain. And the norm for expected weight gain is in comparison to the WHO 2006 weight velocity standards. Moderate malnutrition uses those same normative standards. Less than 50% of the norm counts as moderate, and less than 25% as severe malnutrition. Above the age of 2, up to the age of 18, we look at weight loss as percent of usual body weight. 5% being mild, 7.5% being moderate, 10% being severe. In my clinical experience, and most people that I have spoken with, this tends to be the most sensitive indicator of malnutrition when you are looking at all of the age-appropriate parameters. So next, we have a decline in weight for length or body mass index for age Z-score. So weight for length is going to be the under 2, and body mass index for age will be the over 2 years old. A decline of 1 standard deviation counts as mild malnutrition. A decline of 2 standard deviations counts as moderate, and a decline of 3 standard deviations counts as severe. And then finally, we look at inadequate nutrient intake, which is defined as 51 to 75% of estimated energy or protein needs for mild malnutrition, 26 to 50% for moderate, and less than or equal to 25% for a diagnosis of severe malnutrition. One other thing to note is that these indicators are less specific and that they don't give a duration or a time frame in order to allow for clinical judgment. We also know that children ideally should be growing, so any decline in growth, weight loss, or reflection of altered or poor growth is likely reflective of maybe some underlying degree of malnutrition. So we've been using these indicators for a couple of years, and we've had great success with some of them. Some of them have been a little bit harder to implement in clinical practice. So one really exciting thing that is going on right now is the Malnutrition Clinical Characteristics Validation and Staffing Study. This study is underway, and it has the following specific aims. The first is to determine the predictive validity of the malnutrition clinical characteristics, or the indicators we've spoken of, in relation to patient outcomes. This is happening for both adult and pediatric populations. Next is to determine the inter-rater reliability of the indicators, so making sure that two dietitians practicing separately would evaluate the same measures, indicators, criteria in a similar manner. And then thirdly, to quantify the amount of RDN care that's associated with improved inpatient outcomes. So this study has a 2-year timeline with a goal of 600 adult and 600 pediatric patients coming from 60 different facilities. The data collection has not yet started. The study has been funded by the Academy's Foundation, and it's administered under the leadership of the Academy's RISA team, which is Research International and Scientific Affairs, and Dr. Allison Schreiber as principal investigator, and co-investigator Dr. Elizabeth Yakes Jimenez, who is director of the Dietetics Practice-Based Research Network. So hopefully over the next couple of years, we're going to be getting some great information, validation, and maybe even areas for future study or opportunities for further research out of this study once it's been completed. So let's dive right in and talk about malnutrition risk in the pediatric oncology population. First, we're going to look at prevalence. So this slide is a little bit busy, but bear with me because I think there's some really great information here that we want to keep in mind moving forward as we talk about nutrition-focused physical exam. So prior to the consensus statement on malnutrition coming out in 2014, we really didn't have a lot of literature talking about malnutrition prevalence in the pediatric oncology population. So this was a study that was published in 2012, and it showed that malnutrition prevalence at diagnosis and during treatment varied based on disease process. So leukemia, which we know is the most common form of childhood cancer, had a 5 to 10% prevalence at diagnosis and 0 to 5% during treatment. And this was not any different statistically than the general pediatric population. Neuroblastoma patients had a much higher prevalence, with 50% at diagnosis and 20 to 50% during treatment. For solid tumors, the information was a lot more sparse, so they had to really estimate, and they gave us the grade range of 0 to 30% at diagnosis and during treatment. And then less is known about patients with brain tumors. One study found that 31% of patients with medulloblastoma were malnourished at diagnosis. So since the consensus statement was published, we have some more malnutrition studies being published looking at the indicators or similar values in order to make a diagnosis of malnutrition. So this study, published in 2015, was a review article that looked at 46 studies, and it found a whopping 0 to 65% prevalence in pediatric cancer patients as defined by either body mass index for age, weight loss, mid-upper arm circumference, or tricep skin fold. So that's not necessarily a super helpful number. There's a lot of numbers that fall within that range. We could have only a few patients that are malnourished, or we could have a majority of our patients being malnourished. So looking at a few more studies, about 25% of children showed a significant reduction in Z-scores for weight for age, height for age, or weight for height at diagnosis. Remember, these are all indicators for a diagnosis of malnutrition. And then another multi-center cohort study assessed prevalence of malnutrition at diagnosis and during therapy at several intervals. This study, although it was published in 2013, did use criteria that are consistent with the indicators in the consensus statement. So 5.8% of patients had BMI for age Z-scores below -2 at diagnosis. During therapy, incidence of malnutrition rose to between 22 and 47% when they looked at a BMI Z-score under -2 or a weight loss of greater than 10% from diagnosis. So again, those are both criteria or indicators for diagnosis of pediatric malnutrition, and that narrows our window, that 0 to 65% range, down to 22 to 47%. What this review also found is that age greater than 10 at diagnosis, a BMI under -1 at diagnosis, or a diagnosis of medulloblastoma were positively associated with a higher proportion of malnutrition time during therapy. So it took longer amounts of time or interventions in order to make that criteria such that they no longer met malnutrition criteria. And then finally on this slide, 33% of children with cancer demonstrated Z-scores under -2 for weight for age, height for age, weight for height, or BMI for age in this 2015 study. What they found is that malnutrition was positively associated with solid tumors and also with those patients that were coming from rural communities. They also found a higher prevalence of wasting in ages less than 5 years. So this gives us some food for thought about some of our patients that may be considered at high risk for malnutrition. So this next slide is going to look at outcomes. So just a couple of outcomes. There's many more than what is listed here, including length of stay, cost of care, but these studies specifically relating to morbidity and infectious complications, mortality or survival, body composition, and quality of life measures. So a few studies listed here found that malnutrition during the initial phase of therapy was associated with worse survival, a weight loss of greater than 5%, remember that's our criteria for mild malnutrition, during the first 3 months after diagnosis was associated with an increased presence of febrile neutropenic episodes with bacteremia in the entire first year after diagnosis. Next study found that despite initial weight loss, body mass index and fat mass increased during and after treatment, resulting in a 100% increase or a doubling of the number of overnourished patients in the study. However, the fat-free mass, which was also low at diagnosis, remained low. So that is going to include our muscle mass, and that is significant for our assessment of muscle wasting during our nutrition-focused physical exam. Then finally, and in my mind, probably most importantly, is quality of life measures, because as caregivers, we really care about our patients and clients being able to maximize their quality of life through their nutrition and the food that they eat. So undernutrition and weight loss were associated with lower health-related quality of life scores, specifically in physical functioning, emotional and social functioning, pain, and nausea. So any way that we can minimize that for our patients during the course of treatment is very significant and a very admirable goal. So next, let's talk briefly about nutrients of concern. So based on studies that look at either inadequate intakes of these nutrients in pediatric oncology patients, lab values reflective of depletion, or treatment-related side effects, although this list isn't exhaustive, these are kind of prime nutrients of concern. The first being vitamin D. There's been much more research about this in the last few years than there had been previously. Vitamins A, C, and E are antioxidants. Magnesium, selenium, and zinc. And there's a few studies listed there if you'd like to read more about it. A few things that I want to point out. You'll notice as we go through our micronutrient exam that there's a lot of physical signs and symptoms for vitamins A, C, and E. There's a few for zinc and selenium, but there's not as many related to magnesium deficiency. Serum levels are not reflective of intracellular status. There's a few different ways to evaluate magnesium level, including the red blood cell magnesium, which are more sensitive than the serum levels. But magnesium deficiency is really common in the general population due to a combination of factors, partially inadequate intake from food sources, high intake of processed foods, we see that commonly in our pediatric oncology population, and soil depletion of all kinds of minerals and trace elements, including magnesium. Magnesium deficiency is also very common in patients receiving platinum-based chemotherapies. There have been some studies that have suggested magnesium deficiency is present in up to 90% of patients receiving cisplatin. Also, magnesium deficiency has been identified as common in patients receiving carboplatin. A couple of other signs and symptoms that you can keep an eye out for in case your patients may be exhibiting some of them are muscle cramps, constipation, restless legs, irritability and depression, headaches, and also refractory hypocalcemia and hypokalemia values. So although those things may not be directly attributable to magnesium deficiency, if you have them going on, if you've identified a low intake in your assessment of what the patient is receiving, and you know they're on a chemotherapy regimen that makes deficiency more likely, then you might want to keep those things kind of in the back of your mind as possible signs and symptoms of a deficiency that you suspect. And then finally, selenium deficiency should really be confirmed prior to supplementing, but there's a number of studies that demonstrate that toxicity of chemo and radiation can be reduced with selenium supplementation. Selenium deficiency in the normal population can also be attributed to soil depletion. Some signs and symptoms of that are muscle weakness, fatigue, mental fog, hair loss, weakened immune system, and selenium deficiency can be common in patients receiving cisplatin. So this next slide is from an open access study that was published in 2015. You may be familiar with some of this table. It's been published elsewhere, but it kind of gives us an idea of the patients that are at high risk for malnutrition. What I like about it is that in addition to tumor type, it also outlines treatment modality and patient demographics. So I have a circle or a square here for you to just really focus on those at high risk of malnutrition. Although we know that cancer treatment can also lead to high risk of adiposity, that's just not going to be the focus of our talk today. So tumor type is listed here for you. I might suggest that we add medulloblastoma to this list based on some of the other prevalent studies that we looked at. And again, a review of treatment modality and patient demographics that might make your patients or clients more likely to develop malnutrition during the course of cancer treatment. So looking at the course of cancer treatment, we really have 3 separate time frames. The first being diagnosis. You can see here that every day 43 children are diagnosed with cancer. So we are commonly in our practice in a pediatric oncology setting going to be assessing patients at the time of diagnosis. During treatment, we also have a role to play. More than 40,000 kids are in cancer treatment each year. And then finally, during survivorship. So 60% of children who survive cancer suffer long-term side effects related to their treatment, and some of those can have nutritional implications. So let's take some of this information and apply the practice of nutrition-focused physical exam to the oncology population. So this little clip here is part of the revised 2017 Standards of Practice in Nutrition Care and Standards of Professional Performance for Registered Dietitian Nutritionists by the Academy's Quality Management Committee. So NFPE can include visual and physical examination, and the standards of practice state that each RDN will obtain and assess findings from NFPE, which can include indicators of vitamin or mineral deficiency or toxicity, edema, muscle wasting, subcutaneous fat loss, altered body composition, oral health, feeding ability, including suck, swallow, breathability, appetite, and also affect. So as we get started with a nutrition-focused physical exam, we'll want to gather some tools. Really all you need to do a fairly complete NFPE are your eyes and your hands. It's helpful to have a tape measure so that you can assess mid-upper arm circumference. A pen light is great for your micronutrient exam. You may want something like a tongue depressor, an oral swab, or gauze when looking in the oral cavity. A dynamometer can be helpful for assessing hand grip strength, which we'll talk about in terms of functional status assessment. And then finally, gown and gloves. Of course, you're going to follow universal precautions that are required by your facility for any of the patients that you see. Techniques that are used in NFPE include inspection, palpation, percussion, and auscultation. Inspection and palpation are what we're going to focus on today. Those are kind of the basic standard techniques that are used in most NFPE, and then percussion and auscultation are more advanced techniques that are beyond the scope of today's talk. So next, before you begin your NFPE, you want to make sure that you've done a thorough medical record review so that you really understand what kinds of things you're going to be focusing on, and maybe so you can identify some risk factors or areas that you can hone in on during your NFPE. You're going to start with a general survey of your patient, as you probably are already doing, and that happens from the second you step in the door. You're going to introduce yourself, you're going to explain the process and the rationale for why you're doing it, and you're also going to ask permission to complete the nutrition-focused physical exam. You're going to make sure that you follow hand hygiene and universal precautions, and this can be done as you're doing the introduction, explaining the process, and asking permission, at the same time as you're completing your general survey. And then finally, there are two types of nutrition-focused physical exam. The first is comprehensive, so that's where we're going to use a head-to-toe review utilizing an organized sequence, and then a focused NFPE, which is a specific system based on medical record review or interview. It can also be related to disease state or diet history. So after review of the medical record and some of the risk factors that we've already talked about for malnutrition in the pediatric oncology population, you may decide that a focused NFPE is what is most appropriate for you to be doing on a regular basis. And we'll talk a little bit more about that as we continue. So we're going to go through the comprehensive assessment, which includes 5 components. The first being subcutaneous fat loss. The areas that we assess there are 4. They are eyes, cheeks, upper arms, and torso and buttocks. Next is assessment of bilateral muscle wasting. We have 6 areas here: temples, chest, shoulders, back, thighs and knees, and calves. We complete a micronutrient exam by looking at the hair, eyes, mouth, skin, and nails. We assess hydration or fluid status, taking into account signs and symptoms of dehydration and edema. Edema can be present as generalized throughout the entire body. That might be noticeable in the face. It can be in the sacral area, especially in our non-ambulatory population, and it can also be seen in the lower extremities. Then finally, we're going to assess functional status using a comparison against developmental milestones, a child's own baseline for activity, and perhaps assessment of hand grip strength using a dynamometer. So first, let's talk about subcutaneous fat loss. So we have 4 areas that we're going to assess here. There's some important landmarks that we need to know about, and then this table lists what you are going to find in a well-nourished individual, an individual with mild to moderate malnutrition, or signs and symptoms of severe malnutrition. It should be noted that nutrition-focused physical exam is based on subjective global assessment. That is a validated tool for diagnosing malnutrition. However, it's not one of the consensus statement indicators. Part of the reason for that is that it doesn't differentiate between mild and moderate malnutrition, and it's more subjective than most of the objective parameters that are currently included as consensus statement indicators. So taking that into account, your diagnosis will not be based on your NFPE findings, but they can help you to determine a degree of severity for malnutrition, especially if you're getting indicators that fall into different degrees of severity. And they can also just make you much more confident in your diagnosis and help you to identify malnutrition earlier than maybe you would if you weren't completing NFPE. So the first region we're going to look at is the orbital fat pads. That's going to be around the eyes. Your landmark are the orbital bones or the eye socket, and the brow bone, which is also called the supraorbital ridge. You're going to palpate around that area using your first couple of fingers. Severe malnutrition findings include hollow, depressed dark circles, loose skin, a prominent brow bone, or a hollow eye appearance. Next, you'll assess the cheeks for wasting and the buccal fat pads. Your landmark are the cheekbones, which are also called the zygomatic or malar bones, and also the upper lip. Severe malnutrition signs are a hollow, sunken, narrow face, whereas mild to moderate might just be more flat cheeks. A well-nourished person is going to have full, round, filled-out cheeks. Triceps are going to be in the upper arm area. You're looking at the back of the upper arm midway between the elbow and the armpit when the shoulder and the elbow are flexed to 90 degrees. Severe malnutrition findings are minimal space between the fingers with the fingers almost touching. Mild to moderate will be some space between the fingers, and well-nourished is going to be a thick fat fold when you roll down to separate the muscle from the fat. Then finally, for subcutaneous fat loss, we're going to assess the torso or the trunk. We're looking at the rib cage, the lower back, and the pelvic areas. Your landmarks are going to be in the front of the body, the costal arch, which is the arch that is the inferior border of the ribs, and then the intercostal spaces of the front ribs and at the mid-axillary line. Mid-axillary line is going to be right down from the armpit, and then you're also going to look at the thoracic and lumbar vertebrae, looking at your patient from behind. You may be able to see some wasting in the iliac crest area of the pelvis, and also you might see wasting in the buttocks for infants and children, where you kind of see loose hanging skin there. Severe malnutrition signs will be very apparent depressions between the ribs and around the costal margin and a very prominent iliac crest, whereas mild to moderate malnutrition can be reflected by apparent ribs with slight depressions in the intercostal spaces and a somewhat prominent iliac crest. So here are a couple of diagrams of the anatomical landmarks that we use to assess fat loss. In the top left, you're looking at the picture of the skull, so that's where we're going to assess orbital fat loss. You can see the supraorbital ridge or the brow bone, and then you're going to palpate all around the orbit here, underneath the eyes, and then up around the brow bone and the sides. You can see the zygomatic bone here for the cheekbones. That's one of your landmarks for assessing buccal fat loss. Then moving across the page to the top middle photograph, that's your mid-axillary line. So there you're going to be looking for evidence of apparent ribs. On the right, you can see intercostal spaces marked by the arrows on the outside in between the ribs, and then the intercostal arch or the costal margin is going to be that area at the bottom border of the ribs. Then for triceps wasting or fat loss in the upper arm area, you're going to be looking at this picture in the bottom left. Hand is going to be bent at, or elbow bent at 90 degrees, think goalpost position, and then you're going to roll down to separate muscle from fat. And then next we have the skull. You can see the location of the buccal fat pad there. It's actually continuous with the temporal area, but you won't be able to palpate it there because the temporalis muscle is in the way. So you're going to be assessing for fat loss in the lower portion of the buccal fat pad, and that's going to be underneath the cheekbone or zygomatic bone and above the level of the upper lip. And then finally, in the diagram on the right that is rotating, that is the iliac crest margin that you can sometimes see in patients that are malnourished. That's highlighted for you there. So next, here's some photos of examples of fat loss. I have a few different photos that are subsequent to these in this presentation, and some of them are kind of hard to look at. If you're a caregiver, you probably don't like to see malnourished children, but they are good examples of some of these signs and symptoms. So you can see orbital fat loss in this middle photo here, this baby that's crying. You see that hollow eye appearance, depressions underneath, it's loss of the orbital fat pad. You can see buccal fat loss a little bit in this same picture. I don't have an arrow pointing to that. It's more evident in the man in the photo on the left. In my experience, kids are late to show signs of buccal fat loss. Sometimes their cheeks will be flat, but the actual really prominent cheekbones are much more common in adults than they are in children. You can see upper arm fat loss in this photo on the left as well as the photo on the right. You can see trunk and torso fat loss in all three of the photos. In the photo on the left, you can definitely see very apparent depressions in the intercostal spaces. Same thing with the photo in the middle. You can see a prominent sternum and clavicle there. And in the photo on the right, that's an example of where you see that loose hanging skin and wasting in the buttocks area. So let's talk for a second about mid-upper arm circumference. The procedure for testing this is to position the child facing away from you with the elbow flexed to 90 degrees in the sagittal plane. The palm is going to be facing up. You're going to palpate the acromion process of the shoulder, then you're going to measure distance from the posterior aspect to the olecranon process of the elbow. Technically, you're going to average two measurements, mark the midpoint, and then have the child relax their marked arm at the side. You'll use a non-stretchable flexible tape to measure around the arm at the midpoint to the nearest 0.1 centimeter, so to the nearest tenth of a centimeter. You'll want to make sure that the child relaxes their arm before you measure. If you do not, that can cause a contraction of the bicep, and it will make the mid-upper arm circumference larger than it actually is. The comparative standards that you're going to use here in your evaluation of mid-upper arm circumference are either the WHO multi-growth reference study data, which includes Z-scores. They're available for ages 3 months up to 5 years. Note that all of the data used in the WHO multi-growth reference study was measured on the left arm. We also have some comparative standards for a wider age range. This comes from NHANES data from 1999 to 2012. That data was used to generate Z-scores for ages 2 months to 18 years. Measurements in NHANES studies were taken on the right arm. You can generate Z-scores for both of these by using pdtools.org. A couple of other things to note about mid-upper arm circumference. It's simple and accurate. It's fairly reproducible. It's very useful in assessment of children whose weights may be skewed by overhydration or fluid retention, edema, ascites, or steroid use. In fact, it's actually recommended as part of the assessment for children with solid tumors. It's more sensitive in changes to muscle and fat than body mass index is, and it reflects a one-to-one change in body mass. So depending which arm you choose may depend upon the comparative standards that you're using. It may depend on the access that you have to the arm or the presence of an IV line. The most important thing is that when you compare one measurement for the same child over time, that you use a consistent arm to do those measures. So whenever you document your mid-upper arm circumference value, I think it's always a good idea to place in parentheses or beside that whether you measured on the right or left arm. So next, let's talk about bilateral muscle wasting. There's 6 areas here that you're going to assess. The first one being temples. You're looking at the temporalis muscle. A well-defined muscle is a sign of a well-nourished individual. A slight depression can reflect mild to moderate malnutrition, and severe malnutrition may be indicated by a hollowing or scooping depression. It may be visible by just looking, but you really need to palpate that muscle to feel the depression for certain. Next, you're going to look at the pectoralis major muscle of the chest. The clavicle is your anatomical landmark. A protruding prominent clavicle is a sign of severe malnutrition. You may be able to slide your fingers underneath the clavicle. A little bit of protrusion can be a sign of mild to moderate, and then a visible but not prominent clavicle and fingers unable to slide under the clavicle is a sign and symptom of a well-nourished individual. Next, we're going to look at the deltoid muscle of the shoulders. Your landmark is the acromion process. A severely malnourished individual may have square shoulders with very prominent bones, whereas mild to moderate might be reflected by slight protrusion of the acromion process with the shoulders not square. You're going to assess the scapula in order to determine if there's muscle wasting present in the back. The muscles you're looking at are trapezius, supraspinatus, and infraspinatus. A very prominent scapula with depressions above, between, and below is apparent with severe malnutrition, with only some areas of the scapula being visible in mild to moderate malnutrition. Finally, we're going to move to the lower body. We look at the anterior thigh and knee for quadriceps muscle wasting. The patella is your landmark. A square, prominent knee with no muscle mass and an obvious depression along the inner thigh is a sign of severe malnutrition. And then the calf muscle is the posterior calf of your lower leg. A thin, flat muscle without definition is going to be your sign and symptom of severe malnutrition. One thing that's important to note here is that the upper body is more sensitive to muscle wasting than the lower body. So if you assess the upper body and don't identify any signs and symptoms of malnutrition, it's unlikely that you will see them in the lower body. Likewise, if you have a child that is only mild or moderately malnourished, you may see signs and symptoms of muscle wasting in the upper body, but not in the lower body. Whereas in a severely malnourished individual, you will likely see signs and symptoms in both upper and the lower body locations. Landmarks here, your top left is going to be the temporalis muscle right outside the eyes. The middle picture, you're going to see the first arrow, the one on the left, is the clavicular head of the pectoralis major. You can see it inserts on the clavicle there. And then the arrow over to the right is part of the deltoid muscle. Next picture over, we're looking at the patella as the landmark, and the red muscle is the quadricep. That line that goes to the right side of the quadricep is where you might see that obvious depression along the inner thigh in a severely malnourished individual. Picture all the way on the right is your calf muscle, and then moving down to the bottom row, in the center you can see the scapula very clearly, and then the picture to the left of that is how the muscles overlay them. It's the trapezius you're looking at with the left arrow. The top right arrow is the supraspinatus muscle, and then the bottom right arrow is the infraspinatus muscle. So examples here of muscle wasting. You can see signs of temporalis wasting in the child in the picture on the left. There's a yellow arrow pointing there. You can see signs of pectoralis major muscle wasting actually in all three of the photos. Wasting in the deltoid area is especially evident in the child in the middle. You can see the very square shoulders and the prominent acromion process. In the picture on the right, you can see a prominent clavicle as well, which is indicative of the pectoralis major muscle wasting as well as the deltoid. Back muscles, you can see in the picture on the right with the scapula being prominent there. In that photo, the scapula are actually a little bit winged. That can be a result of muscle wasting from malnutrition because the latissimus dorsi and the serratus anterior muscles have been wasted, but it can also be a sign of muscular imbalance that can be fairly common. Just because there's scapular winging, but no depressions around the scapula isn't necessarily one of your signs and symptoms of muscle wasting in the back area. And then finally, you can see with these kids, they're very knobby knees, the very prominent patella, the wasting of the quadriceps muscle where you can really just see the femur, no appreciable muscle mass, and same thing with the calf muscle wasting. It's really just a flat, straight muscle without that bulb-shaped presence of the gastrocnemius. So now let's move into our micronutrient exam. And remember as we go through this that we're going to be focusing on those nutrients of concern that we already identified, including vitamin D, A, C, E, magnesium, selenium, and zinc. And I placed asterisks next to those nutrients in any of the tables that follow during the micronutrient exam. So the areas we're going to assess include hair, eyes, mouth, skin, and nails. We're going to look for signs and symptoms of specific nutrient deficiencies, recognizing that those nutrient deficiencies can either be primary, which are the result of inadequate intake, or they can be a secondary deficiency, which is the result of altered utilization of that nutrient. Secondary deficiencies can result from a medical condition or illness, medications, including chemotherapy, treatments, including radiation and surgery. We're going to use the micronutrient exam in conjunction with serum or laboratory markers when available. Remember that we as dietitians cannot diagnose a disease state deficiency, but we can say that the clinical signs and symptoms and the intake is suggestive of this. We also want to remember that the presence of inflammation can skew values, and that may influence the timing of collection, so when we might request to have a serum value checked, or the interpretation of results. We know that some values might be skewed if an inflammatory state is present. And then finally, anytime you identify findings of deficiencies in your micronutrient exam, you really want to collaborate with subspecialists and other members of the healthcare team as indicated. And some of those might be ophthalmology, dentistry, dermatology. Those are all people that I've worked with during the course of my career as a clinical dietitian. So one thing that I wanted to point out is there's so many different chemo regimens that are available these days. And here's a couple of places that you can get some resources to help you identify what are maybe some of the treatment-related side effects pertaining to nutrition that might occur from various chemotherapy drugs. So the picture on the left is from the American Childhood Cancer Organization. This website that is listed there, you can go in and search by drug. It will give you a list in some of the side effects of some of those nutritional findings, including this example has hyperpigmentation, mouth sores, rashes, taste changes, all things you might identify during the course of your NFPE. And then also, chemocare.com is another great website. It will give you, you can look up drugs by drug there, but then you can also look up some of the conditions. So this is just a screenshot of the page on nail changes, and it gives you a whole list there of drugs that can commonly cause those. So let's jump right in and talk about these specific areas. So hair is one of those things that you might be saying, I don't need to assess that. I work in pediatric oncology. But diagnosis is a good time to do an assessment of hair because the hair growing back can be reflective of some nutrient deficiencies that develop over the course of chemotherapy treatment. So although alopecia is likely going to be a side effect of chemotherapy in most of our patients, it also can be the result of iron, zinc, or biotin deficiencies. So they may have hair loss related to chemotherapy, but they could have underlying poor zinc stores as well. Color changes, depigmentation, lackluster quality to the hair can be seen with manganese, selenium, and copper deficiencies. Remember, selenium is one of our nutrients of concern. Easily pluckable hair can be a sign or symptom of essential fatty acid or zinc deficiency. Corkscrew hair, which is also called coiled or swan-necked, can be a sign of vitamin C deficiency, and that is, you can see that over in the picture on the right with the little red circles. Flag sign can be a sign of protein or calorie malnutrition, and lanugo can be a sign of calorie deficiency. So the first two photos here on the top are pictures of an 8-year-old boy that was admitted to a malnourishment center in El Salvador weighing only 19 pounds, which I'm sure you can identify as very low for an 18-year-old boy. He would certainly meet criteria for malnutrition based on Z-scores from his anthropometrics. But also pay attention to the fact that he has alopecia and depigmentation of his hair in that photo on the top left. You can see in the next photo on the top right, this is the same child after only 16 days of renourishment. Here his hair is starting to grow back in. He has slightly more fat and muscle, but he still has a distended belly. So renourishing severely malnourished children can certainly make a difference in the signs and symptoms you might identify during the course of an NFPE in a relatively short time frame, and many children will stay in the hospital for longer than 2 weeks, 16 days, so that you might be able to see some of those changes during the course of their hospitalization. Also, if you see the children multiple times, every time they come in, you can compare to their baseline if you're able to remember that. This picture on the bottom left is the same child when he has been after 6 months of being renourished. So you can see here that he's really a completely different looking child. His cheeks are full, his hair is much darker, his hair is much thicker here. Your technique for assessing hair is going to be starting at the scalp, inspect hair from the root to the tip, looking for alterations in color, pigmentation, distribution pattern, shine, texture, and quantity. Next, we're going to look at the eyes. Your technique here is to have the patient look left, right, and up while inspecting the sclera for color, dryness, or plaques using a pen light in a wide W motion. Then you'll have the child, or you can pull down the lower eyelid to assess the conjunctiva for color or paleness. Things that you might see here in the eyes are angular blepharitis. That can be a sign and symptom of a zinc deficiency as well as some of your B vitamins. Pale conjunctiva can be reflective of some of your B vitamin deficiencies as well as anemias. Night blindness, dry membranes, dull milky cornea, keratomalacia, also called xerophthalmia, or Betos spots are all indicative of vitamin A deficiency. Betos spots are the picture over on the right in the top. It's a foamy appearance, whereas the picture right underneath that is the more advanced stages of keratomalacia or xerophthalmia. This is something that I have seen in my clinical practice. Betos spots can be reversed fairly quickly with vitamin A supplementation, whereas there may be lasting damage from the keratomalacia or xerophthalmia. Ophthalmoplegia and angular palpebritis or inflamed junctiva and swollen eyelids can also be signs and symptoms seen during an NFPE for the eyes. Next, we are going to look at the mouth. You're going to inspect the mouth and lips, the teeth and gums, and the tongue, all for oral hygiene, dry or cracked lips, sores, cavities, bleeding gums, and color texture of the tongue. So signs and symptoms that you might see include angular stomatitis or cheilitis. This can be reflective of some of the B vitamin deficiencies. A smooth, beefy red tongue is B12 or niacin. Purplish magenta tongue is riboflavin. Glossitis can be found with some more of your B vitamin deficiencies or iron deficiency. Pale tongue, B12 folate, iron, and then gingivitis or bleeding gums can be indicative of vitamin C, one of our nutrients of concern, a deficiency there, also known as scurvy. Also niacin, folate, zinc, or vitamin D. Again, zinc and vitamin D being nutrients of concern. So what you are going to look at here in the picture over in the middle left, this is a vitamin C deficiency that is reflective by the swollen bleeding gums. The picture on the right is the angular stomatitis related to the B vitamins deficiency. And then the picture on the bottom left is a pale, smooth tongue. There are loss of, there's atrophy of the taste buds here, and that can be the result of B12 or iron deficiency. A couple other things to note about looking in the mouth. You may see signs and symptoms that are side effects of chemotherapy, such as mucositis or a scalded tongue. That is also relevant to your nutrition assessment because that can certainly impact your patient's ability to meet their needs with oral intake. It can also change up the supplementation regimen that you might choose. And then you can also observe the oral cavity for improvements in mucositis that might indicate ability to meet needs more easily through the oral route. The oral cavity is also a good place to note changes in micronutrient status because the cells in the oral mucosa rapidly turn over, usually every 3 to 5 days or so. Next, we are going to talk about skin assessment. You're going to inspect the skin for color changes, texture, lesions, rashes, skin turgor, hygiene, temperature, and skin integrity. So there's lots of different signs and symptoms that you might see when looking at the skin of your patients. Eczema, although that can be an atopic disease not related to nutrient status, can also be reflective of a zinc deficiency. Follicular hyperkeratosis can be seen on the backs of the upper arms. That can be reflective of vitamin A or vitamin C deficiency. Looking at a few of these others, pellagra is a niacin deficiency. That's going to be the rash that you see in the photo all the way over on the right, where you can see the girl's head and the hands crossed over. Parafollicular hemorrhage is a vitamin C deficiency sign and symptom. That's the picture on the top left. Also, petechiae can be seen with vitamin C or vitamin K deficiency. Poor wound healing and pressure ulcers with vitamin C and zinc deficiencies. Purpura with vitamin C deficiency, similar to petechiae, but maybe a larger diameter and a slightly darker color. Seborrheic dermatitis can be seen, this might be seen on the skin or even in the scalp. That can be a sign of zinc deficiency as well as vitamin A excess or deficiency along with the other nutrients noted here. Then xerosis or abnormal dryness can be seen with a vitamin A deficiency. The picture over on the right of the nasolabial folds, that is seborrheic dermatitis apparent there. So a few other things to note about skin for patients undergoing treatment for various cancers. Purpura can be caused by thrombocytopenia, so that might not necessarily be reflective of a nutrient deficiency. Also, you can see impaired wound healing with patients receiving steroids such as prednisone or dexamethasone. Some of the chemotherapy agents that result in hyperpigmentation, which can be a darkening of the skin either overall or it can be localized, often in the nails, the darkening of the tongue, the gums, and over the finger joints. That's going to be common with chemotherapies that are alkylating agents and anti-tumor antibodies. So just a few examples: cyclophosphamide, cisplatin, ifosfamide, etoposide. And then the final skin finding that you might see, there's something called radiation recall, which is a redness that resembles a severe sunburn at the site of previous radiation when certain chemotherapy drugs are given. So you might identify this rash or this apparent sunburn-looking discoloration in patients that have received a multitude of chemotherapy drugs, but some of the ones that we see more commonly might be doxorubicin, etoposide, 6-MP, daunorubicin, or methotrexate. So next we are going to look at the nails. So a couple of findings that you may identify: koilonychia can be a sign of anemia or iron deficiency. Mottled, poor blanching, pale nails can be seen with vitamin A and vitamin C deficiency, both nutrients of concern. You may identify Bowes lines, which are transverse ridges. They're horizontal grooves. You can see in the top right photo, hopefully you can see, that there is actually an appreciable groove in the nail there. It is transverse, and you could feel it with your thumbnail as well as see a slight color change. That can be reflective of severe zinc deficiency, hypocalcemia, or sometimes it can also be seen in patients receiving chemotherapy. Muerke's lines are transverse white lines that can be the result of malnutrition or hypoalbuminemia. That's going to be your top left photo. So rather than a ridge like with Bowes lines, it's just going to be a color, and that line, the Muerke's lines, are because of an abnormality in the vascular nail bed. So those colored lines are going to disappear when you depress the nail and blood is squeezed from the vessels beneath. This lesion is in the nail bed, so it does not move with nail growth, and it also disappears when protein levels normalize. And then you can see in the bottom left photo, Mees lines, which is not listed in the table to the left. That's because Mees lines are a common side effect of chemotherapy, not necessarily a reflection of nutrition depletion. What I want you to see here is they look very similar to Muerke's lines, but here Mees lines are bands in the nail plate. They frequently affect multiple nails, although they can occur singly. They are classically associated with arsenic poisoning as well, and so you may see them with some of the platinum-based chemotherapy drugs. And then also those Mees lines are going to grow out as the nail grows as well. So then just a couple more things from this table. Splinter hemorrhages, that's the photo on the bottom right, is a sign and symptom of vitamin C deficiency. And then magnesium deficiency can be reflected in brittle, soft, dry, weak, thin, or easily splitting nails. So next, let's talk about hydration and fluid status here. Dehydration, we have some examples of lab findings, clinical findings, and physical findings. Some of them are similar to findings of malnutrition, so you'll want to identify if, for instance, you see sunken hollow eye appearance. Is it just because of dehydration, or is there also fat loss in the orbital fat paths present? I'm not going to read all of these things to you here. Same with overhydration. You're probably familiar with the lab findings, the clinical findings, and some of the physical findings that may be present in a state of overhydration. So let's talk quickly about edema and malnutrition. In a well-nourished individual, you won't see any fluid accumulation. Your exam area is going to be the anterior surface of the foot or the sacral area over the posterior pelvis in non-ambulatory individuals. The technique is that you press on the middle to distal surface of the foot for 5 seconds, and you're going to observe for pitting, which you can see in this photo on the right. Mild to moderate pitting that persists for up to 30 seconds is indicative of mild to moderate malnutrition, whereas deep pitting lasting greater than 30 seconds can be seen with severe malnutrition. Note that certain chemotherapy agents can cause chemotherapy-related, sometimes called cancer swelling. Dasatinib is one drug that sometimes this can be seen with. So next, we're going to look at functional status. A few things that we're going to assess. One of them is going to be the baseline activity level. We'll ask questions about usual energy and activity levels, assess for severity of dysfunction, worsening impairment, or changes in function over the previous 2 weeks. And we'll review changes in comparison with the child's own baseline rather than with their age-matched peers. Developmental milestones, you're going to note developmental delays, but you'll evaluate functional impairment through changes in activity level or regression in skills from the child's own baseline. And then finally, you have the option to get an objective measurement of functional status through assessment of hand grip strength using a digital dynamometer. Studies in adult populations have found that grip strength shows an earlier response to nutritional changes than even labs or anthropometrics. Comparative standards are available for absolute and normalized grip strength. Normalized takes into account the child's weight, which might be appropriate if you have a patient who is kind of an outlier to the norms. And those values are available for 6 to 80 years of age based on NHANES 2011 to 12 data. So note that hand grip strength does not quantify malnutrition, but changes over time for an individual can be suggestive of improvement or deterioration of nutrition status. Also, things to note are that it requires calibrated equipment, trained clinicians, and the ability of the patient to follow directions. Then you're going to compare it against age and sex-specific reference data. So I'm not going to read over this. This is just a chart of developmental milestones taken from CDC information so that you can compare what your client or patient is able to do compared to their age-matched peers. And then next, we're going to pull it all together by looking at all of these things, fat wasting, muscle wasting, and the micronutrient exam, as well as assessment of hydration status, mid-upper arm circumference, and grip strength in a head-to-toe approach. So starting at the top, we're going to assess all areas for hair, eyes, mouth, temples, cheeks, chest, shoulders, arms, skin, and nails, rib cage, back, and pelvis, thighs, knees, calves, feet, and ankles. So to demonstrate for this for you, I have a quick little video. It's just over 4 minutes that is going to show you this demonstration of assessment of fat and muscle wasting, as well as micronutrient status, and also doing the mid-upper arm circumference and hand grip strength. This video is nothing super professional. It's just me and my son showing you what to do. I don't do everything perfectly in the video, but I'm still going to show it to you because I want you to understand that you don't have to do everything perfectly either. You can start in one area, practice. The more you do it, the better you'll get. But this at least will give you an example of how to combine all the components at one time. And I am going to play it now. All right, so the last couple of things we're going to talk about here are the NFP focus areas for the pediatric oncology population. We have already reviewed high-risk subsets by tumor type, treatment modality, and demographics. We've talked about the use of mid-upper arm circumference as an early and sensitive indicator for changes in nutrition status. We've discussed a few chemotherapy side effects as well as some resources for getting more information related to that. And we've talked a little bit about the timing of interventions because our goal here is to use NFPE to identify malnutrition as early as we can so that we can hopefully prevent the deterioration of nutrition status and then improve outcomes in the end. So looking at the phases of cancer treatment or the course of cancer treatment at diagnosis, it's really recommended to complete as much of a comprehensive NFPE as able. Hopefully you can get a good baseline, then you'll have something to compare it against as you follow the same child throughout the course of their treatment. During treatment, we're going to prioritize muscle wasting over fat wasting for a couple of reasons, and especially muscle wasting in the upper body because that is more sensitive than the lower body. So one of the hallmarks of cancer cachexia is muscle loss that is either combined with fat loss, or there might not be fat loss present. It might just be muscle wasting. So that's going to be a more important indicator for us. Mid-upper arm circumference is going to be a great way for us to assess quickly and objectively during treatment responses to our nutritional interventions. Mid-upper arm circumference really should never decrease. It should always be increasing if the child is maintaining their nutrition status. Hand grip strength, we can look in the mouth, we can look in the eyes, the skin, and the nails. And then during survivorship, we also want to consider late effects of treatment, which may have nutritional ramifications. There are late effects that can be apparent with the teeth, eyes, skin, growth or endocrine function, and bone health, as well as different considerations if you have a client that has, or a patient that has had limb salvage or amputation. You can't necessarily follow or compare their weight at diagnosis and look at percent weight loss if they've had some kind of procedure that would therefore change that. So that might be a time that you would be looking at mid-upper arm circumference or other indicators of nutrition status. So to wrap things up here, children undergoing cancer treatment are especially vulnerable to the development of illness-related malnutrition. Malnutrition and overnutrition, too, are negatively associated with quality of life measures. As I mentioned just a second ago, NFPE can help RDNs to identify the presence of malnutrition sooner, intervene earlier, and minimize deterioration of nutrition status with the goal of improving outcomes. And finally, NFPE helps you as the RDN to provide the best possible nutrition care for your patients. And just a little side note related to that, it really helps you to establish a rapport with your patients and their families. They have faith in your ability to care for them and make sure that they are receiving the best possible nutrition care. And in turn, you may find that your job satisfaction actually improves through those improved and enhanced relationships. So I know we've covered a lot of material in a short amount of time. If you have any questions, please feel free to reach out to me. I always am happy to answer questions for people. Sometimes the questions will come up when you're actually working with your clients. My email address is listed here, and if you scan this QR code with a QR reader on your smartphone, it will add me to your contacts, and you won't even have to write down my address list. So just a couple of quick acknowledgments. These are some of my partners in crime in our effort to spread the message of nutrition-focused physical exam. So thanks to them, I've had lots of learnings from them and from working with them. And then finally, thank you for your attention. That is all.
Great, Holly. That was a fantastic presentation. Thank you very much for the information.